My name is Mary Mucko. I am a specialist on the Provider Outreach and Education team at WPS-GHA. I will be your speaker today, and assisting me is my friend and colleague, Ellen Barra. We begin with this disclaimer that we use in nearly all our education to remind learners that although we made every effort to provide information that is current, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to your questions based on the facts given. And finally, CMS prohibits recording of this presentation for profit-making purposes. Remember that we're recording this webinar, so you'll be able to access it later on our YouTube channel and on our website. You may have noticed in our advertisement that our agenda shows that this presentation focuses on data. In their internet-only manual, publication 100-09, it's chapter 6, CMS instructs the MACs to analyze and provide education based on common submission errors. Claim submission errors include those that result in rejected or denied claims. CMS actually requires that we maintain a provider data analysis program that produces a list of those most frequent claim submission errors for providers in all of our jurisdiction. These rejections and denials include common or inadvertent clerical or administrative errors and other types of errors that could be prevented through outreach and education. So for today's webinar, I advertised that I plan to discuss data for specialty 08 providers, that is family practice providers. I mentioned that I would cover and include common rejections and denials, ways to fix or avoid the rejections and denials, and I also said that I would provide helpful resources that are going to help you fix and avoid those rejections and denials that I'm going to talk about with you today. Finally, I advertised that I would answer questions about those common rejections and denials that I'm discussing today. So to fully understand rejections and denials, it really is important that you recognize the path that a claim takes, or what we sometimes refer to as the life of a claim. This is really a simplified graphic on how a claim gets into our system. Of course, the service is provided, the provider submits the claim, and our system might reject that claim. And when that happens, a 277 or 999 report is generated and provided to the provider. This slide describes that claim submission. Most providers submit claims electronically. There are very few providers who qualify for a waiver under a law that prohibits payment of any services or supplies when the provider didn't submit an electronic claim to Medicare. Now, to confirm claim receipt, providers should use the 999 report. Providers would use the 277 report that's generated. It offers more specific information. So our electronic data interchange, our EDI staff, has provided helpful information in companion guides that appear out on the EDI website. And I've actually hyperlinked here on this slide the 276-277 companion guide for you. These are guides, or these reports are going to help clarify and further define data content requirements for electronic claims. So it is based on these reports, or the information on these reports, that you'll know if the batch is rejected and if you need to correct or resubmit the batch. Here is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. Again, the service is provided, a claim submitted to Medicare, but something's illogical, incorrect, or invalid, and a notification prints out on the remittance advice that the claim is unprocessable. It's being rejected. On this slide, I've provided a side-by-side comparison of a rejection and a denial. And these are really two very different things. And some people use these words interchangeably. I find myself sometimes using denial instead of rejection and vice versa. And then I need to correct myself. On the left side of this slide, you'll see a rejected claim is one that is unprocessable. It's returned on the front end. It's not actually adjudicated. The reason why that claim is rejected or deemed as unprocessable is because something's invalid or incorrect or even missing on that claim. For these services, because they're never really processed, there are no appeal rights. What you need to do is resubmit the service. There are codes that appear on the remittance advice for rejected claims. You'll find an MA130 and a C0 or a CO rather 16 code on that remittance advice. The MA130 remittance advice code explains to you that the claim contains incomplete or invalid information. There's no appeal rights. Because that claim is unprocessable, what you need to do is submit a new claim with the complete or correct information. The CO16 code is a group code that means contractual obligation, and what that really means is that the provider cannot bill for the service. The patient is not liable. You need to correct the service and resubmit it. On the right side of this claim, you'll see information that pertains to denied claims. Denied claims are actually those claims that are adjudicated and Medicare denies the payment or denies the service because these services failed to meet the payment criteria of Medicare. These could be based on law or what we call statutory requirements. Perhaps the denial is due to the services not meeting medical necessity. When we talk about frequency denials or utilization parameters, these are a form of medical necessity. There are other denials such as eligibility that could also occur, just for some examples. When a claim is denied, the MA01 code will print out on the remittance advice. It's a remittance advice remark code that states if you don't agree with what we approve for the services, you can appeal our decision. And that during that process, the person that or the individual that processed the individual claim would not take part in the appeal if you request an appeal. It also provides for you the time frames you have in order to submit an appeal for that there I caught myself, folks, that denied claim. All right, so this then is a graphic that shows the path for a processed claim or one that's actually adjudicated. The service is provided, the claim is submitted, and there is a decision to either pay the claim or the service on the claim or deny it. And then, of course, the remittance advice is generated. Let's talk about that remittance advice for a moment. Sometimes we call this the remittance notice. Sometimes people will shorten it up and call it the remit or even the RA. Most providers receive an electronic remittance advice or an ERA as opposed to a paper remittance or standard paper remittance SPR. Now, depending on how the claim processed, it may include information about any adjustments that are made to the claims. I'm going to get myself caught up here, I apologize. Any adjustments made to the claim or even denials. So it could include information about something that was missing. Sometimes the RA will provide a notice to you about a refund or an offset. And the ERA actually provides payment information about the transfer of funds. For example, the transfer of funds or payment processing from a health plan to a healthcare provider's bank. Now, there are codes on the remittance advice. I talked about them just a little bit before that provide information about the claim. Claim adjustment reason codes or CARCs explain why a claim paid differently than billed. A remittance advice remark code or RARC provides more details about an adjustment that's described by a claim adjustment reason code. Another type of code that appears on the remittance advice is a group code, and these are the codes that convey the financial responsibility for any unpaid portion of a claim balance. So a CO, one that I mentioned earlier, contractual obligation, means that the provider is liable. And if it is a PR group code that appears on the remittance advice, it means that the patient is financially responsible. You can find code lists on the Washington Publishing Company's website. This is the company that maintains those codes for CMS. You can find a link to the code lists on their website. There's links embedded here on this slide so that you can easily find that information later. Now, I do want to mention that we understand that some of the codes that print out on that remittance advice, those CARCs and RARCs, may be a bit cryptic or may even be out of date. Some of the examples I will include a little bit later on for you, but one I can think of right offhand that I want to share with you is that some of these code messages and some of my slides include those reason codes exactly as they print out on the remittance advice. Some of them might include an outdated acronym or one that's no longer being used by Medicare. WPS has no, we can't make any changes to the reason codes, how they print out. However, if you look at the WPC's website, the Washington Publishing Company's website, you are able to make suggestions to them, suggestions about those code lists that are used. So I just wanted to point that out to you in case you have any suggestions for the Washington Publishing Company. Here are a couple of great resources if you are seeking more information about the remittance advice. These are actually available out on the CMS website. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. And for those of you that are not familiar with MAC, that acronym, MAC, MAC stands for Medicare Administrative Contractor. WPS GHA is the Medicare Administrative Contractor for jurisdictions 5 and 8. And this includes the states of Iowa, Kansas, Nebraska, Missouri, and Indiana and Michigan. After reviewing your remittance advice, you will need to choose the action that you need to take. And there are sometimes multiple actions you can choose from. For an unprocessable or rejected claim, you'll need to fix the error and resubmit the claim to Medicare. If the claim or claim line denied, as I mentioned, there might be multiple actions to choose from. You might be able to simply resubmit the service, or you might be able to use the clerical error reopening or SIR process to fix clerical errors. CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors. I'll talk more about that process later in this webinar. Another action to consider is an appeal. The remittance advice will provide appeal rights when they are available, and I'll discuss appeals a bit later also in this webinar. Registered users of our transactional portal can render a clerical error reopening or request an appeal using the transactional portal that's available from our website. You'll need to register and use your login to access that transactional portal. The information in it, of course, is secure. These self-service tools really do offer the most efficiencies. What I'm talking about here is the clerical error reopening process, or using self-service such as the transactional portal to request an appeal. This is the fastest way to get the job done. Our portal user manual provides illustrations for those functionalities that the portal offers, and it also includes step-by instructions on how to use those portal features. I want to talk about that clerical error reopening process just for a couple of minutes. This is that process to correct human or mechanical errors. Clerical errors or minor errors are limited to those in form and content. The final bullet on this slide links to a helpful resource on our website. It provides some great examples of those situations that can and cannot be processed as a clerical error reopening. It also explains how to request one via telephone or fax should you choose not to use the self-service option to perform or render the clerical error reopening. Examples of acceptable clerical error submissions are those that are mathematical or computational mistakes, transposed procedure or diagnosis codes, inaccurate claim entry or data entry, misapplication of fee schedules, or even computer errors. For claim denials, most often, with very few exceptions, you can request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. There are 5 levels of an appeal. The only one level is rendered at the Medicare Administrative Contractor, and that is the redetermination. The beneficiary or their representative can request an appeal on any service processed for them, but providers and suppliers can only appeal those services for which they accepted assignment, with an exception that I'm going to mention in just a couple of minutes. For unassigned claims, providers or suppliers can act as the beneficiary's representative. However, the beneficiary does need to sign an authorization statement. One of those statements is, as for an example, the CMS 1696 appointment of representative form. In addition, here's that exception. Providers and suppliers may request a redetermination on an unassigned claim if Medicare denied that service or the service as not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge. And in those cases, the provider or supplier would need to refund any amounts over collected from the beneficiary. There are 5 levels of appeal, as I mentioned. That first level is the redetermination, but for all 5 levels of appeal, there are time frames that apply when submitting an appeal request. Additionally, there's a minimum amount in controversy rather, that applies to level 3 and level 5 appeal. You can combine like denials or similar types of denials on more than one claim to reach the amount in controversy. There's a lot of great resources out there available for appeals. We could go on and talk about only appeals for the next 60 minutes if we had that amount of time, but we don't today. So I do want to share with you some helpful resources for appeals. The first is a resource that appears on our website. It's called How to Appeal a Claim Determination. Provides telephone numbers, fax numbers, mailing addresses, and such if you are submitting an appeal request to WPS GHA. Remember, that's the redetermination, the level 1 appeal. The next bullet there, the second bullet, is another resource that's one of my personal favorites that I like to share when I talk about appeals. It's actually a process flowchart. It appeals on the CMS website. They update it annually. So if this is a resource that you look at and like to use, just like I do, you want to be careful at the end of the year to make certain, once the calendar year changes, that you're looking at the flow chart and it has been updated by CMS, because those amounts in controversy could change from year to year. What I like about the flow chart is it shows all 5 levels. It tells you the amount you have, or the time frame you have to submit your request, and it also tells you the amount of time the contractor or agency has to render their decision on that appeal request. It has the amounts in controversy on it. You know, it's just a quick look at, easy to understand and follow flowchart. So I wanted to share that with you today. The next portion of this presentation includes a discussion of the data that I used to provide common rejections and denials for Specialty 08 providers. That means those providers who self-designated themselves with a primary specialty of family practice. The data that I looked at was all states in MAC jurisdictions 5 and 8 for specialty 08 family practice. Claim submission dates included in this data that I looked at and analyzed to present for you today is 10/1 of 2023 through March 31 of 2024. And that data that I looked at was last refreshed on April 10 of 24. And what that means is that any claims that were submitted for that date range after 4/10 of 24 are not included in the data that I'm going to present. So here then are the common rejections by reason for specialty 08 providers. You can see the common rejections listed here on this slide. These are those reason codes that print out on the remittance advice. Those that I said may be a little cryptic or might have an outdated acronym in them. Those numbers that you see here on this slide represent the number of rejections for that particular reason. So the most common denial reason for this specialty for the time frame I looked at and analyzed data was rendering physician number invalid or missing. It's the reason codes actually says submit a new claim. There were over 18,000 rejections for that reason. Here is one of those situations that I kind of have to chuckle at because it says denied in this actual reason that prints out on the remittance advice for the unprocessable claim. It says denied, but it's really rejected. It's an unprocessable claim. So as I mentioned, some of these seem to need a little work maybe, or some are outdated, some of the information in them, or even cryptic, these reasons. And we can't change these at WPS. It is only that Washington Publishing Company that can do that. So what are you going to do to fix this or avoid this type of rejection or unprocessable? You're going to take a look at the rendering physician number on that claim. Make sure that it is valid. There may have been a situation where the number was transposed. Perhaps it was missing altogether. So you'll need to fix that and resubmit the claim. The next one is claim lacks information needed for adjudication. Over 7,000 rejections. For this situation, what you're going to want to do is take a look at your claim and try to determine what it is that's missing from the claim, or the information that it lacks that's needed for adjudication. Remember, there are situations where more than one reason code will print out on that remittance advice, so you're going to want to take a look at all of them. This may be a situation where you're going to want to look at the claim form instructions. Those are available in the internet-only manual. There's also a crosswalk that crosswalks the paper claim form to the electronic version claim form to see if something on that claim that's required was missing or lacking. The next reason, missing, incomplete, invalid ordering primary identifier. CMS has published information on services that require an ordering provider, and if that information is missing or incomplete or invalid when it is required on the claim, it's going to reject. Over 6,500 claims or claim lines rejected for that particular reason. Next is invalid or missing modifier, over 2,000 claims. We have on our website under the Claims Topics Center, and I'm going to share a lot of resources with you later on today during this webinar. There are modifier fact sheets for nearly all modifiers, and I would look to make certain, number one, was it valid when you reported it on your claim? You know, is it one that applies for that particular procedure code? Was it keyed correctly? Was a require, excuse me, was a modifier required and simply not placed on the claim? These could be reasons for rejections. The next common rejection by reason, and this one shows up not just on the common rejections for family practice, but on a lot of the claims for other specialties as well. And this is that the claim must be submitted to RRB. And in this case, that acronym RRB stands for Railroad Retirement Board. Railroad Retirement Board processes claims, or there's Medicare through the Railroad Retirement Board. Those that have worked for the railroad are eligible for Medicare through their retirement. Those claims are processed not by WPSGHA, but by a MAC, the Railroad Board MAC, and that is Palmetto GBA. So the claim must be submitted in this case to RRB. And the way that you can tell if a beneficiary is eligible for Medicare through the Railroad Retirement Board would be to look up the eligibility files for that patient. Another suggestion that I could make is ask to see that Medicare card as your patients present for services. If the patient is a railroad retirement beneficiary, it will say that on the bottom front side of their Medicare card. It's pretty bold. It shows Railroad Retirement Board. So you'll know that that patient's claims need to be submitted to Palmetto GBA, not to the Part A and B MAC. Next up, more common rejections by reason. Here's another case where it actually says or prints out denied. There's a couple of them on this particular slide. It says denied, but we're talking about rejections here. Field 11 of the HCFA 1500 must be completed. There, folks, is an example of an outdated acronym being used on the reason code on the remittance advice. The HCFA 1500 is now the CMS 1500. HCFA was the Healthcare Financing Administration, now known as CMS, the Centers for Medicare and Medicaid Services. So in this case, Field 11 or Item 11 on the claim asks, is there another payer that's responsible for this claim or another insurance primary to Medicare? And what happens most often is that the answer is no, but the claim form requires something in that field. So you can't just leave it blank. If there is none, no other insurance primary to Medicare, you need to actually place the word none in that field. Over 1,800 rejections. Missing procedure modifier, over 1,700. I talked about modifiers already and what you need to fix or avoid them. The next one is a situation where a CLIA number is invalid or missing. For certain clinical labs based on a law, the Clinical Laboratory Improvements Act, there needs to be certification for those labs that are being rendered in the provider's office. Once certified, there's a certification number that's provided to that provider that is rendering those lab services, and that number needs to be placed on the claim when billing for those clinical laboratory services. If it's invalid, keyed wrong, perhaps, or missing altogether, the claim is rejected or the claim line is rejected. The next one, the hospital should bill Medicare Part A for this service. That one's, self-explanatory. There were 860 rejections for family practice providers because the claim should have been submitted by the hospital. The last of the common rejected reasons that I've listed here is that the place of service conflicts with the procedure code. You need to submit a new claim. So what that means is that for the CPT or HCPCS code reported on the claim, the place of service isn't one that's eligible for that CPT or HCPCS code. Now, for these types of situations, if you have questions about place of service and if they match up with that procedure code, you can call customer service and ask them, does CPT code 12345 or does your system allow this code in place of service and provide the place of service? What you don't want to do is call customer service and give them background information about the specific situation. You need to keep it kind of vague. You need to ask, will your system accept this code in this place of service? Can't provide any information about the patient or the diagnosis or such, because that's really considered coding of sorts, and we are prohibited from offering coding advice. So you need to watch how you ask those types of questions. I thought it would be interesting for you to see, I just talked about the common reasons for rejections for family practice. These are for those common rejections I talked about, the most commonly rejected HCPCS and CPT codes. No big surprises here. Quite a few lab services, that would be those services where the CLIA number might be invalid or missing, or might be other reasons. There's also E&M codes there. There is the 20610, which is an intra-articular injection. The 99499 code is an NOC code, and it didn't hit the list of most commonly rejected or reasons for common rejections, but it is an NOC code, and we do have published on our website instructions for when you're billing a not otherwise classified code. It tells you in that resource on our website what it is that you need to place in item 19 or the electronic equivalent on your claim in order for us to be able to adjudicate that claim. The GO 439, I believe, is a subsequent annual wellness visit, and typically what's happening with that is that perhaps someone else had already billed the service, or the time that needed to elapse before the subsequent visit has not yet occurred. So that's what's happening there with that one. All right, let's take a look at those common denials. I'm going to talk about a few of these, and even one on the next slide, or a couple of these and even one on the next slide all together. Over 23,000 claims denied, duplicate charge paid, that next portion that you see there, the question mark 002XX. If you saw this, if this was an actual denial reason that printed out on the remittance advice, there would be a date there. Duplicate charge paid, such and such a date, on claim, on that next group of question mark 001, and those X's would actually appear as a claim code or an internal control number for a claim. So it would be telling you that we've already paid this claim, or paid for this service on another claim, and here's the claim number and here's the date. 23,400. Look at that third bullet, duplicate charge of another claim. There again would be the internal control number, or ICN, now being processed. That means there's another claim in the system currently being processed that's a duplicate, 10,430. You'll see on the next slide there's some also duplicate charges over 7,000. Now if you add all those claims up, and that's a lot of claims that are being denied because they're duplicates. We have a resource on our website, or that speaks to denials for duplicates. And there's some recommendations here. Don't just automatically resubmit a claim after 30 days or every 30 days just because Medicare hasn't paid for that claim yet. You need to use due diligence to check to see if that claim has already been submitted. If it's been paid for already, if you're using a billing service that automatically on a schedule resubmits claims when payment has not yet been received, ask them to stop doing that. It's considered abusive. And really, when you total up all of those claims, if you were to, let's say you were to put a dollar amount on each of those claims, what it cost you to prepare and submit those claims, as well as what it costs Medicare to process those claims, that's a lot of money. So we ask that you check out the resources to avoid these duplicate denials. The second bullet on this claim is one that's popping up often on the webinars, or on the data that I'm analyzing for the webinars that I am providing. Collection of fee-for-service during periods of managed care. That's a little cryptic. I had to check with some folks at uh, at WPS, GHA, to see, does this really mean what I think it meant? And it absolutely does. Over 22,000 claims were denied for the data I analyzed because the beneficiary has chosen a managed care plan or a Part C Medicare plan. So rather than submitting the claim to WPS, the claim should have been submitted to Medicare Part C plan. Or Medicare Advantage plan. We have some great resources out on our website. We've done some, to address this. You're going to need to check patient eligibility again. It's being submitted to the wrong contractor or wrong plan, or not the plan, but to the MAC, and it should have been submitted to the plan. So this is certainly a denial that we want to avoid. It's a costly claim submission error, and we want to make certain you have the resources to avoid those. And that, of course, would be eligibility. You're going to check. You can use the IVR that I'm going to talk about in a little bit. You can use our transactional portal. You need to check the eligibility and make certain that you're submitting claims to the proper the plan or to the proper MAC. All right, let's move on here. Payment included or separate payment not made for the service. Do not bill the patient. There are some certain services that are always bundled. They cannot be their payment for their services are included in other services on the same day. If you look at the CMS relative value file, you will see status codes listed for each of the CPT codes and HCPCS codes that appear on that file. If there is a B in the status column, that means that a separate payment cannot be made for that service. The payment for that service is bundled. It's always bundled. So I would suggest for this type of situation, make sure you're checking the status code column on the relative value file. Similar to that bundling type of denial is the next one, payment included in another service received on the same day. Over 7,000 claims denied. For these, what you'll need to do is go to the National Correct Coding Initiative, procedure to procedure edits, to determine if a modifier is allowed to unbundle payment. Sometimes the services are indeed bundled, and the payment can't be made for the column 2 code that appears on those procedure to procedure edits, but sometimes there is documentation in your medical record documentation that would allow you to append an NCCI or National Correct Coding Initiative associated modifier in order to receive payment for that second service that's rendered same day by the same provider for the same patient. So that's a form of bundling. There's that duplicate charge that I had talked about already. It's just one of many different types of duplicate charges or duplicate denials for Medicare claims. Next bullet, claim must be sent to the EGHP. EGHP is how it prints out on your remit, but that stands for Employer Group Health Plan. This means that there is another insurance that is responsible for the payment of that claim first before Medicare can process the claim. It is the Employer Group Health Plan. So those are situations where you need to check eligibility to determine to whom you need to submit the claim. Next, denial. Denied service or units of service are exceeded. This is another type of the National Correct Coding Initiative edits. This would be those medically unlikely edits where the units of service that are billed for a claim line exceed, or for services on the same day for the same patient, exceed the medically unlikely edit amount. Now, some of those aren't published. We recognize that, and this is on purpose. CMS has chosen not to publish some of the medically unlikely edits, but many of them are, and what you'll need to do to avoid this type of situation is to refer to those edits. Some of them, of course, are going to deny correctly. Some of them are those situations where you may have medical record documentation that justifies the billing and provision of those services that exceed that MUE. And in that case, you would need to submit an appeal and request payment for those services when the units of service are exceeded. Next is not covered when performed, referred, or ordered by this provider. Again, similar to something I talked about earlier, CMS publishes information on their website for those providers who are eligible to perform, refer, or order services. I provided that resource for you in the resource section of my presentation. Next is the services are denied because the patient is in a hospice. This again is another type of eligibility situation where you're going to need to make certain you know to whom to submit that claim. But in this case, these services denied because the patient is in hospice and the claim was incorrectly submitted to WPS-GHA. And finally, the last of the common denials that I'm going to talk about today is that the time limit for filing the claim has expired. And for this is that exception I talked about earlier. I said for most services that are denied, there is a right to appeal. For time limit expiration, there is no appeal rights. Over 3,000 claims were denied during that time, or the denials were made for family practice providers. There's actually a resource on our website that talks about timely filing. Talks about when in Medicare can or cannot, or how you can go about requesting a waiver for the timely filing. And so it provides you with examples of those situations that we're often asked to waive timely filing for a particular item or service and what CMS says about that. All right. Here are the common denials by code for those services or those reasons that I just covered. Again, you're going to see some E&M out here, some AWV services. The G2211 is showing up there. That's that complexity code. And also a couple lab codes and some handling codes. So all those common denials by HCPCS codes. Now, at the end of today's webinar, I'm going to give you an opportunity to make suggestions for future education. If you think it's a good idea to look at data for these codes and explain specific reasons by code why these are denying these CPT and HCPCS codes, make that suggestion when you fill out your survey, and I can pull some more data to see specifically, you know, maybe the top 5 reasons why this CPT code is denying, or the top 5 reasons why this CPT code is rejecting. Something for future webinars that we can consider. All right, I just wanted to let all of you know that we do have different ways we can break down this data. Some of them are available in a dashboard that we use. When I say we, I mean provider outreach and education people in my department. They have made available to us that just, you know, just by putting in various filters, if you will, I can pull information on this CPT code for this type of specialty to see why the claim is rejecting or denying. We can also pull by state, by county. You know, we can further break down the data by HCPCS code in the state or HCPCS code in county, or CPT codes. We can also look at trending, and I want to show you an example of trending. For this was actually a denial that was made, or denial reason. The code description states AWV G0439 within 12 months of G438 or G0439. And then it provides for us the current claim count for the current 3 months, 375. It'll provide the claim count for 3 months prior, 408, and then shows a difference in claims, minus 33, and the percentage of change is minus 8. And this, folks, is what we want to see when we are looking at data. We want to see a trend that's going down. We want to see rejections and denials decreasing. So this is a great example to show what it is we look at, or how we determine what we need to provide education on. Just it's a lot of fun to look at the data. It's very easy to pull at a glance. Some of it is because some of it appears in that dashboard, while other information that we request, that data that we request, has to come from our insight team, our data informatics team. All right, I wanted to provide some resources for you, and in that in my ad for today's webinar, I did mention I would provide resources. So here then are those resources that will help you avoid these rejections and denials, or fix them. This is the requirements for a Medicare claim. You can find the claim form data set in Chapter 26 of CMS's Internet Only Manuals, and I'm going to pull the internet open here in just a minute, or websites rather, I should say, to show you some examples. In Chapter 26 of the IOM, you will find those instructions, but it's for a paper claim form. Well, most of you aren't billing on paper anymore, so I wanted to provide for you the resource that is what is called the CMS 1500 to ANSI 837 5010 crosswalk, and I want to show you what that looks like, because a lot of the rejections that I talked about today was because something was missing or in an illogical format, or something was required but wasn't there on the claim. So here is our website, and to get to that crosswalk, you can actually use the embedded link on your handout. But if you're on our website and you need EDI information, look on the home page under Quick Links and choose EDI. It will open the Electronic Data Interchange website. And we have, of course, Medicare, TRICARE, and our commercial line of insurance at WPS. But if what we're talking about today is Medicare, so I want to open the Medicare website for our EDI. And here are those companion guides I talked about a bit earlier, the 277, 299, and the 999 guides that our electronic data interchange tells you the content of a claim that's required. But that crosswalk, here's where I found it and where I linked to. And I'm going to pull this open, or click on the link to open it up, to show you what it looks like. Because the IOM has the information, what's required on the claim form, and it's by item on the CMS 1500 claim form. If you look in the left-hand column here, I'm trying to get rid of this, but not working for me here. If you look on the left-hand side of this crosswalk, you'll see these item numbers. These item numbers coincide with the items on the paper claim form. So if information belongs in item 19 on the paper claim form, you can come out to this crosswalk, and this will tell you then the data element description, the loop, and the version, where the segment of the claim where that information needs to be included when you're submitting that electronic claim. This status column is very, very helpful. You'll see several S's here on this page, but over here there's an R. It says principal diagnosis code belongs in item 21, or the electronic equivalent. If you look at the key on the bottom of the page, R means a data element that's required in order to process the claim, and S means it's situational. And by situational, what we mean is a data element that has to be completed, but only if other conditions exist. So this is really helpful when filling out the claim form and making certain that all of the information is being provided that's needed to process your claim or pay it correctly. Okay, so that's the crosswalk. Next, here is the resource or article on our website that speaks to how to correct rejected claims. And this is listed by remark code. So very, very similar to what I showed you today. All of those reason codes, remark codes, it tells you the specific remark code of the RARC or CARC that appears on the remittance advice, and then it tells you how to correct it. So that's a web resource. Similarly, that was a web resource for rejections. I'm providing for you now our website resource for denials, common claim denials. And the resources are shown based on the reason or remark code, and these are as well. However, we've categorized those reason and remark code denials for you. So here then is I mentioned earlier, we have a resource on our website that speaks to denied claims for duplicates or denied claims for bundling, denied claims for entitlement. So these categories appear out on this resource, and we list the reason and remark codes for each of these categories to help you avoid these denials in the future. Here's a link to our website because the employer group health plan was one of those denials most common for family practice providers. I've included for you a link to MSP or Medicare Secondary Payer questions and answers. We also have helpful recordings or videos out on our YouTube channel. You'll see that's listed there in the last of the bullets. There is a link to our live events webpage, our encore presentations, which are our recordings that appear on our website for 90 days following the event. I've included for you LCD and article lookup tool. We didn't have a lot of rejections and denials for family practice based on LCD and article, but I did want to include that for you because that is a great resource to know about. That appears actually out on our website. Just getting it ready to pull over and show you. If you are on our website, on our homepage, the code lookup tool, LCD and article lookup is right here. So you can see some of my previous searches, if you will. They appear here for you, so it kind of remembers what you've looked for before, and of course you want to tell the tool what it is you're looking up. So for example, you're looking up an LCD on, with the word Mohs in the title, and then it would show here, for example. And of course, I'm just picking something out of the top of my head. For you, family practice, it wouldn't necessarily be Mohs, but that's a great tool to know about. It will provide you with the link to not only the local coverage determinations or LCDs, but for the article lookup as well. And when we say article, what we're meaning is the companion guide for the policy. All right, let's take a look at more resources. Here are those modifiers, fact sheets, or where you can get to a listing of those fact sheets because that hit common rejections and denials for family practice. Place of service codes for professional claims. I've included that list for you because we did have the example today of that this place of service is not valid for this procedure code, so I wanted to make certain you could get to the place of service code so you have the descriptions of them. Ellen is hosting a place of service webinar coming up. Check out our news items or the live events webpage for when that is posted and available for registration. Proper billing for various Medicare Advantage HMO claims. Those are those situations where the patient has chosen Medicare Advantage or Medicare Part C. It's kind of an eligibility denial, but this will help you learn a little bit more about Medicare Advantage claims. Freedom of Information Act in case you want to request additional information for your place of business, information on rejections and denials specific to you. I didn't pull by specific PTANs or NPIs, but that information is available. You need to request it through FOI, and there may be a charge for it. Partnering is opportunities for various associations or societies to invite someone at WPS to come in and do a live presentation or do a virtual type of education for their particular group or association. Coverage database is where you can find the status code for claims. Is it bundled? Is it always bundled? Never going to receive payment separately for it? That would be the Medicare coverage. Oh, no, let me back up. That's not the Medicare coverage database. That is the relative value file. I apologize. The Medicare coverage database is a national searchable depository of the national and local policies. This is a great tool that tells you how to use that. We talked about the CLIA rejections or denials today. This is the resource we make available that explains the program and what it is you need to have on your claim. Beneficiary Notice Initiative provides the links for ABNs if you're looking for that kind of information. Again, not specific to what we talked about today, but I think it's important to provide it for you. When you receive a medically necessary denial, you would need to consider, if you believe the likelihood Medicare will deny your service, need to consider presenting your patient with the BNI in advance. Contractor directory is an interactive map that tells you this is where you need to send your claim if your patient is a railroad retiree, or this is where you need to send a claim for hospice. Those were a couple of examples that popped up today, so I wanted to have you to have access to that. Here are those National Correct Initiative or Correct Coding Initiative edits, those that would have you would use to see if your service bundles into another service rendered on the same day. That's the procedure to procedure edit. And for those services that exceed the units of service you can bill in a given day, you'd want to be looking at the Medicare and CCI medically unlikely edits. More Medicare Advantage resources. Here is that information. I mentioned to you that CMS maintains as a guide for physicians and suppliers who bill Medicare Part B, ordering and referring. So if you're looking for a listing of providers who are eligible to order and refer, you can get there from here. This is an embedded link where you can get to the page and then choose accordingly what it is you specifically want to look for. That's a CMS website. All right, the IVR is one of those tools that I mentioned to you. This and the next one I'm going to talk about. For both of these, you can check eligibility, find claim status, and details about your rejections or denials or claims. 24 hours a day, 7 days a week. There is limited functionality outside business hours. And with the IVR, this is the tool that you would use your voice or telephone keypad. We make available an operating guide so that you can easily use it. And similarly, I've just mentioned, you can check eligibility, claim status, claim details by using the WPS GHA portal. This is the self-service portal that is secure. We do have a portal user manual available. You can link to this on every single one of our web pages. There's a link at the top of the page to the portal user manual, as well as a link in the big blue box that appears at the bottom of every single page. This is the time that I have hoped to be able to take live questions. Unfortunately, I have run out of time today, and I won't be able to take questions live, but I will be happy to follow up with any questions, and I'm going to be talking in just a minute about how you can do that. I do want to mention, I didn't get the slide into this deck because this deck was already published, but there is, CMS is teaming up with Noridian to host a provider enrollment seminar, or conference that is. It's going to be in late August of this year, I believe the 28th and 29th, and it's free. You don't have to pay for admission to the conference. It's going to be held in San Diego, California, and registration and scheduling information is available out on the CMS website, and I am having Ellen add that information to the chat feature so that you have information. Another great way to find that is just simply to go to the CMS website and search for Provider Enrollment Conference. You can get to it that way as well. Our greatest compliment is when you recommend our education to others. Please consider doing so to help us reach all of those providers in our MAC jurisdictions. This assures current and effective education for everyone. On behalf of myself and Ellen and our provider outreach and education team, I do want to thank you for your participation. We look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everybody. Have a great day.